the idea that clogged arteries are in part due to inflammation goes back 150 plus years. But really, it was a Harvard researcher, Dr. Paul Ridker, that created a blood test at Harvard called the high sensitivity C-reactive protein, maybe 25 years ago, did the research to show that it very commonly is elevated, and in those that are elevated, they have a greater risk of heart attack and stroke.
Have you made it past menopause, or are you going through it now? I'm Dr. Pat McShane, and on the Women's Health Span Voices podcast, I'll guide you through the menopausal transition and beyond, helping you to thrive in this powerful time of your womanhood. Hello and welcome. I'm delighted to have with Women's Health Span Voices today a very important voice, that of Dr. Joel Kahn, who is a cardiologist. And he is a podcaster and an influencer as well. And I will let him tell you a little bit more about his practice. But he would, I would say, have a holistic approach to cardiology and heart health in women, women's health in general, and especially from a plant-based diet focus, which we will definitely get to during our interview today. So anyway, Dr. Kahn, very wonderful to have you with us today. Welcome.
Thank you.
Yeah. I think we can start with the idea that many women are not aware that heart disease is the major cause of mortality in women, and also what we call morbidity, or the process of not having optimal health and daily routines caused by various symptoms from heart disease. So I think women tend to be more afraid of breast cancer or dementia, and those are certainly relevant. But heart disease is what we should also be paying a tremendous amount of attention to. And maybe you might want to comment on that a little bit, Dr. Joel.
Yeah, I agree completely. They're both, any cancer topic's important, but women should know and very often don't know. And it's an amazing statistic. It's not a good one, but 7 times as many women will die of heart disease than die of breast cancer.
Yep.
And even if you take a group of women with breast cancer, more will die of heart disease than of their breast cancer. Now, maybe occasionally it's at age 92 in bed quietly, but very often, it's in your 60s and 70s, occasionally younger, when you've got lots of life plans left. And the real tragedy of heart disease is it's very often without any warning systems, and that should have been symptoms, not system, without any warning symptoms. There's a quote by a famous doctor I love, Peter Diamandis, that the body has an amazing ability to hide disease. It's true for breast cancer. It's definitely true for heart disease. You can come off the pickleball court and be in an emergency room 2 hours later without any real warning. So even women with breast cancer, heart disease is a bigger risk. And we know so much, and we're frankly doing so poorly about taking a woman by age 50 for sure, maybe age 45, definitely at menopause, and fully characterizing their heart disease risk accurately. And then putting a plan in place. And the plan in place might be all good news, pat on the back, see you in 5 years, 1 year, whatever the answer is. But it may be you are developing heart disease and you have certain factors in your blood you didn't know about. We just got to do this. We're much more aggressive with cancer screening than heart screening.
Interesting.
And it isn't not available. It isn't expensive. It isn't elitist. We just don't do it. There's very strong data that the conversation in the medical world is so often cancer, dementia, diabetes, obesity. These are all very serious problems. Many of them overlap with heart disease very seriously. But we don't have that, heart disease conversation the way we should.
Yes, and instructing women, educating women, which is obviously what we're doing today. Another tragedy of this whole situation is that I've read estimates that as much as 80% of heart disease is preventable, which is what you're telling us we should be trying to approach, a time in life when you can make changes in a whole bunch of things, and we'll talk more about those lifestyle factors and also clinical recommendations. Blood pressure and diabetes management are huge as well. So that's been a neglected area as well. Another kind of tragedy, I would say, that's a pretty strong word, but is that most of the basis of current cardiology practice is based on studies performed in men and for men many times decades ago. So we're catching up more now with research for women's presentations, how women tend to have their symptoms and their conditions. But it's a struggle. It's an uphill battle to catch up with accurate information for women. Maybe you could comment about that, because both the presentation and to some extent the risk factors and maybe even the testing looks a little bit different in women than it does in men.
Yeah, a little bit different. Most I've been practicing for 37 years. And when we talk about symptom detection, we're waiting till the disease is very advanced. And yes, there may be differences in some women than some men. Men may get more of a pressure, a tightness, a burning, a squeezing on heavy physical work or emotional work or super cold weather. Women may feel more fatigue, palpitations, shortness of breath, back pain, heartburn. But if you're waiting for that to make the first diagnosis of heart disease, you're
Yeah.
waiting essentially for arteries to be 80 or 90% blocked. And although you just said it is possible for 80% of atherosclerotic heart disease to potentially be prevented, that program has to start at age 20, 25 if you're really going to prevent yourself. I am turning 67 very soon. I have absolutely no atherosclerosis in my body. I know that. I've tested every vessel. I don't say that boldly and, with bravado. I'm very grateful for it. But I started working out every day at age 18. I started eating an exclusively whole food plant-based diet at age 18. Thank you to the horrible cafeteria at the University of Michigan dormitory that swayed me to go over to the salad bar, not over to the gray bar, whatever they were serving. I actually was lecturing about 15 years ago to a large group of dietitians in Michigan. And a man walked up to me and said, "You just told your story about why you're plant-based." He goes, "I was your food director at your dormitory, 1977. He goes, "You did a smart move. We had about $1 a day to feed you guys. And the meat was not a good choice." So he goes, "Good choice." So, but if you're waiting for symptoms, you're waiting for 80 or 90% blockages, and that might mean a stress test and ultimately a catheterization and a stent. We don't want to wait till women have breast cancer. We want to, institute a lifestyle program, which is reasonably effective at lowering the risk of breast cancer and other serious conditions that women worry about. And earlier, the better. I mean, the earlier you get off fried food, heavy sugar diet, and sitting on the couch as a female, the healthier you'll be for many, many conditions. So I see mainly asymptomatic people. And I give them good or bad news, but I give them very accurate news about their cardiovascular risk status, and actually more than risk, the actual disease status. And it's very simple. There clearly are women that go through the entire gamut of cardiac testing. Maybe they are experiencing some symptoms that are concerning, and they just prove not to have the typical atherosclerotic narrowed arteries that cardiologists have long looked for on stress tests, on catheterization, and now mainly we use heart CT scanning. They just don't have it. And we talk a lot about small vessel. There's another fancy word, microvascular, a concept that the little tiny vessels may get diseased and cause symptoms. We can't see them. It's usually a presumed diagnosis if it sounds typical enough. We can't stent them. We can't bypass them. We treat them with medication and risk factor aggressive management. So there will be some women with symptoms that don't prove to have seriously blocked large arteries. We still worry about these small arteries. But in general, you want to go way upstream. Again, age 45 to 50, doc, I just came back from Colorado, where you are. I skied for 5 days. Nobody skied for 5 days in Colorado.
Not this year.
Maybe went hiking, biking, but you didn't go skiing. Well, yeah, I felt great, and there still is the opportunity through blood work, through simple testing, to create a diagnosis and a plan. Here's your next 5 to 10 years. We're gonna, keep you healthy.
And the American
However,
Cardiology
and
Association just recommended much earlier screening and interventions last month. Yep.
I see these little tiny thin, and I don't say that in any pejorative way, yoga women,
Mhm.
55 years old, absolutely no symptoms, super fit. And we do the proper evaluation of blood work and cardiac imaging, and they have significant disease way beyond expected. A lot of that is genetic. You can identify genetic factors. We'll talk about some of the blood tests you must have. And then you work on improving it. Can't completely resolve all risk. We all breathe air, drink water, are around plastics. We can run, we can't hide. But if your lunch today is, a bacon cheeseburger because you're stressed out and you're running to your next meeting, you might want to rethink that.
French fry. Don't forget the French fries and the soda.
In
Right.
there, be
Yeah.
sure they're in beef tallow to make Bobby Kennedy happy, please.
Yes. Maybe we can back up a little bit and talk about how we go from being basically at lower risk than men in our reproductive ages to the same risk, or basically it's the major cause of death in both women and men in our postmenopausal years, and some of the roles of estrogen and the other hormones that decline with our menopause, and the effect that that has on our lipids and on our vessels and so on.
Well, there's certainly, there's an overlap between men and women, smoking risk, sedentary lifestyle risk, processed food, heavy meat diets, dairy diets, to excess sugar. I mean, men and women react poorly equally to those, undiagnosed high blood pressure. One of the big ones that men and women both suffer is disrupted and inadequate sleep. Then magically women hit menopause. And, within a year, usually there's just a complete collapse of hormone support, including hormone support of blood vessel function. The fancy term is the endothelium, the inner lining of arteries that fight plaque and keep our arteries clean. And we're pulling out one of the best defense mechanisms a woman has when her estrogen and her progesterone and her pregnenolone and other hormones plummet, to very low levels. And, there were more than adequate studies in the 90s that placing women on hormone replacement therapy for symptomatic menopause and potentially even just because of, a year without periods or starting it earlier, I had a very sizable effect on reducing heart disease risk with time. This was discussed in cardiology literature, gynecology literature in the 1990s with enthusiasm and support. And then came along the famous and somewhat evil Women's Health Initiative, 2002, 2003, claiming that there was an increased risk of breast cancer and maybe blood clotting. Various analyses since have largely put the Women's Health Initiative results into major question. Seems to be an unfortunate, heavy author bias to present the data as bad as possible rather than with equanimity. So women obviously got off hormones, and I think they've suffered a lot in the last 20 years. And fortunately, we're seeing that pendulum swinging, whether it's as simple as a estrogen patch and a progesterone by mouth if you have a uterus, whether it is a specialist who prefers bioidentical hormone treatment and follow up with saliva or urine or lab testing. But, we're coming back to understanding that one way to keep a woman youthful and keep her cardiovascular system youthful and protect her brain and protect her bones and help secure that her sleep is as reasonable as possible is to throw the WHI out the window and go with all the other studies that are out there. Now, if you just focus on bioidentical hormone therapy, there's not a lot of research. There's an enthusiasm in the functional medicine world. My wife is on those kind of therapies for about 15 years. My mother is 93. She's been on bioidentical hormone therapy for probably 35 years. And her brain is like an IBM computer and, very healthy lady. So, these are all
You
important
just
informations. I read the book that I'd recommend to everybody, not a book I wrote, called Estrogen Matters in 2018 when it came out. I had missed There's a second edition came out 2024. So I just finished that, Estrogen Matters. I certainly would encourage, I don't know if you've read it and agree, that
I haven't. Who's the author?
yeah, Avram. There's two, a man and a woman. One has an MD, must be 80 years old, and a very academic physician who was involved not just as a clinician, but in many research trials. I'll get his name in a minute.
Okay, that's all right. We can look it up. Estrogen Matters. Okay,
Why
great.
taking hormones in menopause can improve a woman's health is the
Great,
subtitle.
great.
I think I have it as a hardcover. Yeah, Avram Blooming and Carol Tavris, and it's a
Excellent.
very academic book. I mean, you know, everybody's got some story to tell on Instagram, but we still got to go back to trials and literature, analyses, and the book does a great job. It's heavily referenced, so it's always my go-to in the clinic. You know, you're a gynecologist telling you don't need it, but please read this book and consider it. Yeah.
You sort of answered one of my questions, but then brought up another issue, which is how long should one stay on hormone replacement therapy? And in the case of your wife and your mom, you think in their instance that this is good for them to keep going well into their later menopausal years. But you also, in the next paragraph, said there isn't a lot of research on this, obviously.
Particularly, you know, bioidentical hormone therapy. You just got to find a doctor who's done courses, been mentored, that you have confidence in. There's websites that guide you. You know, it's kind of funny. We just got in 2026 updated guidelines on cholesterol management. You may even have alluded to those first ones in about 8 years. And the mantra in the cardiology primary care world is the longer, the lower, the better. Talking about cholesterol. You know, the longer you have it at a reduced level, the better will be your cardiac outcome. Because we know that heart disease grows very slowly, very progressively, sort of like an indolent cancer, but it's growing. And if you start managing your cholesterol when you're 25 or 30, a much bigger impact than if you start managing your cholesterol at age 65. But when we come to hormone replacement therapy, you know, it's been the opposite. It's been the least amount for the least amount of
The
time.
shortest
Off of
time.
it as quick as possible. So maybe that mantra will spill over into hormone replacement. I talk to all my female patients, unless they're in their mid 70s, because we do know there's this thing called the timing hypothesis that within 10 years of your last period, starting hormone replacement therapy is considered of optimal safety. One of the problems with the Women's Health Initiative study was many women were in their late 60s and mid 70s when they started hormone therapy. And a lot of them had known risk factors like hypertension and obesity, and some of them clearly had heart disease they didn't know about. So if you're in that age range, you probably need a real good cardiac evaluation. But if you're 52 years old, just go for it. You know, there's nothing. Many studies, including probably 3 in the last 3 months, say if you went through menopause early, 40 to 45, maybe hysterectomy, maybe just menopause, it's a major risk factor for future heart risk. So you don't want to drag your feet on that issue.
Yeah, I'm glad you brought that up because that's something that I wanted to mention is our reproductive history and its impact on our cardiac risk factors. And you brought up early menopause. I'm going to read here from my list. Early menarche, people who get their first period at age 8, 9, 10, instead of, more commonly 12, 13, are at higher risk. Those who've had a hysterectomy, those who had their first birth at an early age, those with multiple miscarriages, stillbirth, preeclampsia, gestational diabetes, and more recently fibroids, which I thought was kind of novel, that women with a history of fibroids were more likely to have heart disease. Care to comment on that?
No, we are slowly learning all those things as cardiologists. I mean, we're supposed to be asking about preeclampsia and eclampsia, pregnancy-induced hypertension, pregnancy-induced type 2 diabetes as risk factors for a woman who's 10, 15, 20 years out from those events and some of the others you just mentioned. So whether you're a female or a male cardiologist, it shouldn't matter. It has to be upgraded a little bit to consider OB-GYN history in terms of your current cardiovascular risk. But we're kind of moving past risk. In fact, there was a interesting study just published, doesn't surprise me at all. If you go to these brand new American College of Cardiology 2026 cholesterol guidelines, one of the things we're supposed to do, you can do it as a person, you can do it as a doctor, is go over to calculators. The hottest one is called the Prevent calculator. You just put that in a search engine and it'll come up. And you put in your cholesterol and your HDL and your smoking history. You even put in your zip code because there are regional differences in heart disease. You put in your kidney function if you have that data. It's things like that. It's a little more updated than previous ones. And it'll spit out a 10-year risk of having a heart attack based on those calculations. And if you're under maybe age 55, it'll give you a 30-year risk, which is more valuable. If you're over age 55, it doesn't try and calculate a 30-year risk. But there just was a paper published where they took 500 people that had a heart attack. They looked at their chart, a month or 2 months before the heart attack. Totally unexpected, out of the blue heart attack. And these risk calculators were terrible. They very often judge these people who had a heart attack as being in the low risk group. There's so many things these calculators don't check. The high sensitivity C-reactive protein is one. My favorite little particle, this is a teaching moment for your viewers, is there is a genetic cholesterol called lipoprotein a. This is a book I wrote a couple of years ago. And we learned since 1963, but really the last 20 years, that 20 to 25% of people inherit from one or both parents the ability in their liver to make this cholesterol. It's never checked on a routine cholesterol panel. So you may have had your cholesterol checked 20 times. You haven't had this checked. You just got to check a box. You either can pay $35 cash or your doctor can bill it under various codes. You should find out. And it's actually not my opinion. It's been recommended since 2019. These new guidelines just emphasize it. Everybody should know their level. If you're in the 75, 80% that just don't make it because your liver doesn't have that gene, hallelujah. It's not a good cholesterol particle. It causes atherosclerosis, strokes, heart attacks, peripheral leg blockages. It also causes one of your heart valves called the aortic valve to get calcified and become problematic. And there are people that inherit the ability to make a lot of that particle and they don't develop heart disease. We're trying to figure out how that is, just like there are smokers that don't get lung cancer. How is that possible? But some people, I have patients in my practice as young as 32, 33, women and men, that had heart attacks. And after the full standard evaluation, they told the patient, we don't know why, came to my clinic. We did the 20-tube lab draw. That's pretty typical. If they don't pass out, we keep on drawing blood. And they had very high levels. And sometimes the family history is already concerning. Multiple members, you can almost track through who probably had the lipoprotein A. But very often the family history is not that distinctive. You just have to get that lab test done. The struggle is, and this goes back to hormones, there is no FDA-approved drug right now for this cholesterol. Statins do nothing for this cholesterol. A baby aspirin a day is now recommended if you find out you have a high level of this. But this level, if you are in the 20 to 25% that inherit it, it will go up higher with menopause. And it will come down to your baseline with hormone replacement therapy. It's not going to be the only treatment needed. We are awaiting results of trials right now by drug companies of unique drugs that have been created to battle lipoprotein a is what it's called, or LP a. But hormone replacement therapy is, when you ask, why do some women seem to have a lower risk of heart disease on hormone replacement therapy? One answer in the complex mix is they are keeping their lipoprotein A level lower than it would have been otherwise.
Interesting. Very interesting. How about C-reactive protein? I recently saw a report showing that was a better predictor. Again, we're talking now about risk factors rather than behaviors, but Is that part of your recommended screening for all women if they haven't had it routinely with their total cholesterol and triglycerides?
Yes, it is. The idea that clogged arteries are in part due to inflammation goes
Yes.
back 150 plus years. But really, it was a Harvard researcher, Dr. Paul Ridker, that created a blood test at Harvard called the high sensitivity C reactive protein, maybe 25 years ago, did the research to show that it very commonly is elevated. And in those that are elevated, they have a greater risk of heart attack and stroke. And then we had to learn why. And, when you talk about women going through menopause, all of a sudden you're sleeping poorly in menopause. That will elevate your inflammation panel. Maybe you gain some weight during menopause. That will elevate your inflammation panel. Maybe you just have lost the drive to go to the gym and stop working out as aggressively. That will elevate your inflammation panel. Plus many other things like psoriasis. Psoriasis is a heart risk factor and it drives the inflammation tests up. Poor dental health. Oh my God, the dozens and dozens of studies that say if you want a good brain and a good body and a good heart, get to your
Take care
dentist.
of your teeth. Yeah.
But it is a common finding that we will identify under a root canal a little hidden chronic infection. And we
Hmm.
solely picked it up because the high sensitivity C reactive protein was high. Might take a special CT scan that some dentists do. And then that gets addressed and the C reactive protein comes down. But most of it is just keep it simple, stupid, highly processed, ultra processed, driving the kids to, soccer team, music, practice, and you're getting a yellow bag through a carryout window because you just didn't have time to make dinner for the family. And you're eating garbage body, high inflammation. Got to go back. I'm not a big fan of Bobby Kennedy's new food pyramid, but the concept that real food, homemade food, home cooked food, simple ingredient food like a tomato is a good idea is certainly something I support.
I just saw a study showing that people who ate a lot of ultra processed foods in their thigh muscles had much more fat infiltration, even if they were normal weight and good exercisers. So, diet impacts our bodies in a much more profound way than I think we've classically understood. I want to go back real quick to one point, which is that taking hormone replacement therapy on a topical basis or an oral basis or a sublingual basis is very different than taking it on a vaginal basis with a cream or a ring, or because people who I think at any age with genital urinary symptoms related to low estrogen should not hesitate to go on to estrogen therapy vaginally to get rid of the urinary and the vaginal and the maybe sexual symptoms of menopause. And those tend to get worse with our age. Even if somebody's in their 70s and they're having recurrent UTIs or just uncomfortable vagina, difficult sex, etc., that they should not hesitate to go on vaginal replacement. And I presume you would agree with that, but the gynecologist in me is like, yes, got to take this stuff.
Would agree with what you said, but maybe for the optimal heart, bone, brain, long-term health, it may take a more comprehensive hormone support
Yeah.
program
Yeah.
than
I
just that.
would not hesitate to
This is
start.
obviously key.
Shingles vaccine, I just read something about that may impact on our cardiac risk. I know it reduces our risk of dementia. So I would, again, and it's a terrible disease. You don't want to get it, shingles, but maybe for other reasons you might consider the vaccine. What's your take on that?
You're absolutely right in quoting. And the only thing I'd add, I'm not a fan, frankly, good or bad, of recommending the flu vaccine to my patients, but there's also now data that, these are not prospective double-blind randomized
Yeah.
studies. These are databases of fairly large groups of people, and the database indicated whether they got the shingles vaccine or not, whether they got the flu vaccine or not. And it's more than one. Maybe for the flu shot, it's only a couple. For the shingles, probably up to 5 or 6 studies suggesting there are unexpected benefits to either avoiding shingles. That might be why it impacts cardiac risk. Shingles is an inflammatory disease and it's painful. And even though it's usually self limited, usually, not always, and it is treatable, but the vaccines, they are not the controversial mRNA genetically engineered vaccines. These are standard vaccines, and the flu vaccine also. So people need to have that famous conversation with their medical team about whether they should line up and get these. It's still not part of the standard recommendation, but I think just in the last couple weeks at the American College of Cardiology, there was a report in about a 250,000 people that in follow-up in people over age 50, heart disease risks seem to go down almost 50% if the answer to the question, did you get a shingles vaccine, was yes, I did.
Yeah. Of course, these studies, as you say, are retrospective. They're not double-blind controlled studies. So the healthy user effect, maybe people who got the vaccines were more healthy to start out with. That's one of the major biases in any kind of study like that. Yeah. So if you're on the fence, maybe that'll push you over a little bit towards getting it. Yeah, I also saw a recent report about light exposure at night. And again, this was population based, zip code based, I believe. People who live in high nighttime light intensity situations have a higher risk of heart disease. And again, you spoke earlier about good sleep habits and sleep patterns. I just did a video on circadian rhythms, and it seems to impact, again, every organ in our body has its own biorhythms, certainly the brain, the gut, and it seems like probably the heart as well. So sleep patterns and light time avoidance at night might be something to consider as well.
And and seeking light during the day.
Yes.
One traditional trick to sleep better is, if you have the opportunity to do it, is get some morning sunshine on your eyeballs. In Detroit in the winter, that's not happening. You might be able to get yourself a light panel and do it artificially, but if you live in a climate where you can walk outside, take your shoes off, stand in the grass, get a little light, do a little yoga, may help you sleep much better. People that are traveling, across international timelines, that's a trick they often do when they arrive in Bangkok, Thailand. Next morning, they'll get out there and get some sunshine, sort of seems to reset the pineal gland. Sunshine helps us produce vitamin D, of course, usually considered
Yes.
a good vitamin. Helps us make, most people don't know, nitric oxide in our skin, which gets in our circulation,
Vasodilator.
blood pressure down and dilate vessels. So I am a sunshine fan.
Mm-hmm. Mm-hmm. Good to hear. Good to hear. Maybe we could spend our last couple minutes here talking more about diet. You've woven that in to many parts of our discussion today, but maybe you would like to tell us, besides avoiding ultra processed foods and fast food, what about plant-based per se versus meat or chicken or fish?
For reasons that are deeply emotional, apparently. We don't argue. We don't literally block people on social media because you like cardio and I like strength training. I mean, we have conversations, we present data. But boy, oh boy, do we block people on social media because they're meat-based advocates, aggressive, or plant-based advocates, in your face. It's a crazy thing, and there's just something about food that's so fundamental and tied in with our childhood. I'm not a psychologist on food, but you can't help but notice it. But so you got to go to the science, and you can't listen to every influencer on Instagram and TikTok and Snapchat and all. Everybody's a doctor. Everybody has an opinion now. Sometimes their doctorate is in toenails. Nothing. They really shouldn't be
Basket
doing
weaving,
too
right.
much on heart nutrition. So you got to
Yeah.
go with the science, and it's very complex. My favorite person in another book, here's another book to read, is called The Longevity Diet by Walter Longo,
Yes.
Longo, PhD, one of the world's most famous researchers on longevity and aging, University of Southern California, although he's native Italian and still goes back half a year. Extensive research. Nothing comes out of his mouth is just an opinion or to sell a vitamin. It's research. He's created some of the best research on nutrition. So in that book, you'll see in a 21 meal a week plan, 3 a day, and he's a big fan of eating breakfast, not skipping breakfast. 18 meals a week are whole food plant-based, lentils and salads and oats and avo toast and soups and the rest. And 3 meals a week are largely seafood and fish. And his research shows that across the world, that is probably the optimal way to eat. Now, I choose not to eat 3 meals a week of shellfish and seafood and the rest because I am plant-based, but I don't yell at my patients. In fact, his data is that after age 65 to 70, emphasizing a little more protein in the diet for avoiding muscle loss, sarcopenia, but you really should be doing some strength training at that age too. You'll maintain your muscle mass
You
better.
need both protein plus weight training or body weight
Yeah.
training. Yeah.
And maybe add some creatine powder if you want to. We're concerned that the GLP-1 agonists like Wegovy and Mounjaro may cause as much muscle loss as fat loss, although a brand new study this week suggests that's not true. There's not too much muscle loss. I hope that's right. At any rate, that's a little diversion. But, so that's one viewpoint. You can't have one paper. 3 weeks ago, a paper was published that said the more red meat you eat, the lower is your risk of colon cancer. Well, that it stands in distinction to 150 other studies that say the opposite. That colorectal cancer risk goes up with red meat in general, certainly processed red meat like bacon and pepperoni, and even higher quality cuts of non-processed red meat. So you got one study, and it wasn't a prospective double-blind study. You got 150 over here. You got to incorporate everything. And it's hard and it's exhausting and it's confusing. And, who's got the time to really be a researcher? Of course, you can put everything in Grok or ChatGPT or something and try and get, you often get a more reasonable and balanced view of it all. But if you put in AI search engine right now, but what's the research for the optimal diet for heart disease prevention? It's somewhere starting at the Mediterranean diet, which is a diet that reduces dairy and red meat and certainly fried food and processed food, home cooked, is a very rich fiber, plant-based diet, and water, not soda, and olive oil, not beef tallow and butter. And you can go from there, major databases, not too many double-blind randomized studies. There is one called the Predimed study a decade ago and one called the CardioPrev study of the Mediterranean diet that really did identify cardiovascular risk benefits. Most of it's just traditional cultures. Yeah, there were no heart attacks in Italy, literally no heart attacks in Italy in the early 1950s. And an American researcher who's some people say notorious, I think he's brilliant, Dr. Ansel Keys, went over to Italy, a little city called Nicodera, Italy, and he talked to the fellow researchers and why don't you guys have heart attacks? He's told them we're having an explosion of heart attacks in Minneapolis in 1951, and you have none. And that led to all the research on the Mediterranean diet and several books he published on the Mediterranean diet. And now the fact that either the Mediterranean diet or a version called the DASH diet, which is a lower salt diet, or a brain-related version called the MIND diet, MIND, or even another version you can look up called the Portfolio diet, all related to this research in the 1950s. You got to start there and move forward. And if you want to prevent heart disease, you just got to eat a lot of brightly colored fruit and vegetables, nuts and seeds, whole grains if you're not, celiac, soy-based products. Don't fear edamame, don't fear tempeh, don't fear tofu, don't fear miso soup. These are, wonderful foods for your body. A researcher in Washington, D.C., Dr. Neil Barnard, MD, highly prolific researcher, double-blind randomized human nutrition studies over 16 weeks showed if you're a woman having menopausal symptoms and you adopt a simple whole food plant-based diet with a lot of soy products compared to a group of women that were left on their standard diet, there's a dramatic decrease in symptomatic hot flashes without any concern about raising breast cancer risk. It's all nonsense. So the data, whether you talk the epidemiology, the basic science, case studies, the blue zones, these longevity studies on people that have lived to over 100, they're obviously not eating junk food generally. And they're not eating generally meat-heavy diets, places like Loma Linda, California. Probably the greatest longevity in the United States, and they're largely a vegetarian and vegan community because of the Seventh-day Adventist Church. They've been studied and published. So I teach a plant-forward diet because they're similar to Dr. Longo. If I have a really sick heart patient, I might emphasize the famous research of Dr. Dean Ornish, which is closer to an all plant-based diet. Actually showed if you have plaque in your heart arteries, you can start to reverse some of it with diet alone. Now we use diet and fitness and meds and sleep, and we go beyond all that. But when that was published in 1990, it was largely a nutrition study and lifestyle study. So you got to stick with the science. We got a little confused by the USDA food pyramid earlier this year. The American Heart Association just published in March of 2026 their updated food guidelines, and it's back to what we call common sense and the bulk of the science. There's 9 rules for eating according to the American Heart Association, and they are not consistent with the USDA new food pyramid, putting the meat and the whole fat dairy at the top of the pyramid. Maybe a tiny little piece of the pyramid, but not at the top.
Yes. And I always hesitate to ask this question, but what about supplements? Again, highly polarizing.
Need another hour there. I'd say the most obvious answer is if you get to a doctor who starts to do blood work for vitamin levels, vitamin D, God, there are a lot of people horribly deficient. The number one in my office is omega-3. We're not taught human body doesn't make it. We're also not taught the human body doesn't make vitamin C. And if you don't eat a lot of salmon or mackerel or herring or ground flaxseed or chia or walnuts, you're not going to get much omega-3. And if you do a blood test, I email people every morning, and it's like my number one email. Your labs look good, but you're still dramatically low in omega-3. And sometimes the only resource is to get them on a vegan or a fish-based omega-3, 1 or 2 capsules a day of a good quality supplement. But vitamin D is profoundly deficient, omega-3 profoundly deficient. B12, a lot of people are deficient, and a blood test called your homocysteine level goes up, and that's not good for your health and your blood vessels.
Especially people in postmenopausal women, that the B12 situation would pertain.
They may stop absorbing it, or
our stomach acid goes down, and
And my plant-based people don't eat the meat sources that sometimes contain B12. So you can target your supplements specifically. Then just throw one more out. Probably starting 50 years ago, research was coming out about coenzyme Q10, also called CoQ10. And now 50 years later, there's tens of thousands of research studies that say it's a difficult nutrient to get from the diet. After age 40, we start to make less and less. If you're on a statin like Lipitor, you basically block your body's ability to make CoQ10. And man, we learn in medical school, CoQ10 is involved in the Krebs cycle. It makes energy. It keeps muscles strong, keeps the heart strong, keeps the blood pressure down, lowers inflammation, improves the lining of arteries called endothelium. So I'm a big user of coenzyme Q10. There is a blood test, and if I see somebody 65 years old and their blood test is great, I mean, fantastic. Somehow your body's still making it. But if you're taking Lipitor or Crestor or generic versions, you're not making CoQ10. You want to verify, get a blood test. If you don't want to verify, just go pick up a bottle. I mean, safest supplement on the planet. I wanted to say in the last couple of minutes, there's only one topic I haven't mentioned. It just hasn't come up. But at the very beginning, we were talking about, that we are able with precision now to take an asymptomatic 50-year-old woman and give her a clue that you are developing heart disease at an early stage or not. And that is a CT scan called a heart calcium CT scan, sometimes also called CACS, coronary artery calcium scan. A test that was developed 36 years ago in San Francisco at the university, widely available for 25 years. The test every primary care doctor ought to be doing on people 50 years old. Costs about $100. Every hospital offers it. You probably need a script where you live from a doctor to get it. Coronary artery calcium score. And now about 10,000 research studies that say if you go for that test and it comes back perfect, that's called a 0 score. your risk of heart disease over the next 10 years is very low. Your need for statins like Lipitor is basically non-existent. That's an American Heart Association recommendation, not just my opinion. And, work with lifestyle. On the other hand, my wonderful Pilates lady, yoga lady, weight training lady, they go for that test. They're perfect. And it comes back horrible. Sometimes we find the lipoprotein A, sometimes we find the C-reactive protein, but sometimes we don't find much, which is distressing. And whether they just added daily aspirin, whether they change their diet, whether they get their cholesterol lowered naturally, eat more oatmeal or other things, we got to individualize. And if you come out zero, it's a really, really good piece of news. But 5-6 years later, you want to go back and repeat the test and prove. So we have a mammogram, we have a colonoscopy, we have a pap smear, we have a prostate test. People don't know that there's a heart test that's scientifically proven. Now, these latest guidelines on cholesterol management by the American College of Cardiology, American Heart Association in the last 4 to 6 weeks have way too conservatively elevated this CT scan very high up in the testing. If these prevent risk calculators aren't very good, we need something better. It's already been shown the calcium CT scan blows these risk calculators out of the water. It's just much more.
Especially if there's family history that, may, even though you're the skinny yoga practitioner. Yeah. Well, this has been fantastic information and very well articulated by you with good background in the research. Follow the science, as you have said many times, and I totally agree. But it's also practical information that we can give women dealing with their primary care doc, their cardiologist, if they have one, what to ask for, what to be doing a little bit in their daily life. And I'm so grateful for your time and your expertise. Thank you so much. Yeah, you're very welcome. If this episode spoke to you, please share it with a friend ready to take charge of her health. And please leave a review. It helps more people to find us.